very much, Lana. We're here to talk about the changes in CPT for otolaryngology, and after a lot of years of not having changes that affect us in otolaryngology, this year we actually have quite a few that we can address. Getting right into your presentation, I have a little disclaimer that says, although we've checked and rechecked for completeness, if you misunderstand or misuse this information, we take, both audio educator and myself take no responsibility. And if I was giving this live, usually I get a little chuckle here. I know probably you've been living with this right now for the past 3 months, that we know that consultations are dead in the water with Medicare, and there's also been a change in the descriptive wording. I'm on slide 3, by the way, on the AMA CPT, because they're sort of in a battle with CMS in terms of what consultations are. When consultations were eliminated by Medicare, AMA came back and re-described consultations to say a consultation is a type of E&M service provided by a physician at the request of another physician or appropriate source, either recommend care for a specific condition or problem, or determine whether to accept responsibility for ongoing management of the patient's entire care of a specific condition or problem. The reason this is important to you is most private payers have not followed Medicare's lead so far in terms of the elimination of the consultations. There are some. I've heard HealthNet is following Medicare's lead, but most private payers, the only place where they're following Medicare's lead is in their Medicare Advantage programs, but in their private commercial products, they are not. So consultation still exists for them, so it's very important that you follow that. So you have two circumstances for consultations in CPT for 2010, and that's to provide opinion and services for a specific condition, or to allow a determination to be made on whether to accept the ongoing management for that patient's care and take that transfer of care for that specific condition. Then on slide 5, CPT changes of 2010 also stresses that documentation or written of the written or oral request of the consultation can be made either by either the consultant or the requesting physician or appropriate source. So that's really important to know. Outpatient consults, which are 99-241 through 99-245, apply to the office and outpatient, which means there's a lot of different places that applies to. That could be the office, that could be the ER, that could be in a hospital outpatient clinic, that could be in observation, which means it could look like the patient has been admitted to the hospital, but they're not because their status is observation. It could be in a domiciliary or a rest home. Whereas inpatient consults apply to when the patient has an inpatient status, which could be a hospital inpatient, it could be a nursing home inpatient, including skilled nursing facility, it could be a rehab patient. Okay, now I'm going to get into the meat of the changes. We've got a lot of changes in the combination or the linkage between the intima integrity section and the musculoskeletal section when we start talking about the excision of lesions or unusual problems with skin, subcutaneous tissue, muscle, going all the way down. So let's talk about that. So in the intima integrity system, we've had the excision of benign lesions, which includes the closure of defects created by the incision, excision, or trauma, but it may require intermediate or complex closure. So it's really important that if you do repair by intermediate or complex closure, that you report that separately. You're throwing away money, and in today's day and age, when the fees are going down, 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 you do not throw that money away. As a matter of fact, the money for the repair when it's an intermediate or a complex closure, and don't let anyone tell you the complex closure includes the excision of the lesion. It doesn't. you're throwing that money away if you're not reporting the repair by an intermediate or complex closure. You have to get your doctors to document it well. They can't just say they closed it. They have to demonstrate the layers that they closed it. They have to demonstrate what makes it a complex closure. But when they do that, you can bill it out with those the layered closures or the complex closures, which are 12031 through 57 for the intermediate, or the complex closures, which are 13100 through 13153. It's very important that you get this documentation, or else you're throwing away money. So how do we really recoup everything we deserve? How do we code correctly is when we're excising these lesions, that we code and report the repair when we're doing something beyond a simple closure, when we're doing our intermediate and our complex closures. Then on slide 9, I go on to say when we're doing reconstructive closures, which are like 15002 to 15261, 15570 to 15770, the excision performed in conjunction, so reconstructive, those are those, but let's also look at 14000 through 14302, which are adjacent tissue transfer. For excision performed in conjunction with adjacent tissue transfer, which is 14000 through 14302, that lesion is not separately reported. This is just an exception to all the other rules that you do. So when your doctors are doing an adjacent tissue transfer to repair taking out of a lesion, so the doctor takes out a lesion and then they repair it with an adjacent tissue transfer, you cannot code the excision of the lesion. You can only code the adjacent tissue transfer. You can only code the 14000 through 14302. So that's a little frustrating, but if you see page 58 for the definition of the intermediate and complex closures,